very much. So it's a great pleasure and privilege and honor to have Dr. Mark Dias with us to give a lecture on the embryology of spinal dysraphism, taking us through the different classifications. As we all know that the nomenclature of dysraphisms can be confusing, and when you don't all agree on what's the nomenclature, then discussing cases and learning from cases becomes even more difficult. So we have a world-renowned expert in Dr. Mark Dias to clarify these points to us. Dr. Dias did his medical school at the Johns Hopkins University, and then his fellowship in pediatric in neurosurgery at his pediatric neurosurgery fellowship in Utah and residency in Pittsburgh. And Dr. Dias has contributed enormously to this literature on spinal dysraphism, and there's a chapter on the classification of closed spinal dysraphism on the book Closed Spinal Dysraphism by Sean Tubb et al. It's well worth reading. Dr. Dias is the director of pediatric neurosurgery at Penn State, as well as the vice chairman of the Department of Neurosurgery there. I came across Dr. Dias back in late 1990s, Dr. Dias, when Dr. Dias was moderating the pediatric neurosurgery listserv of the FAANS and CNS. It was at the time the best thing that was in the internet. It had lots of cases, and I learned a lot, and it was an inspiration for me to push the our listserv to the next level. So without further ado, if I may invite Dr. Mark Dias to give his lecture. Thank you, sir.
Thank you. And really, it's an honor to be able to share some of the what is really my passion and has been my passion for over 30 years now. One of the reasons I got into pediatric neurosurgery was really a love of embryology, dating back to my undergraduate days at the University of California at Davis. So what we're going to do is really twofold, our objectives. One is just to review the early embryology of the nervous system, running from blastogenesis through gastrulation, and then to primary, secondary, and what we'll call junctional or transitional neurallation, which is something that's a recent development. And then to discuss the proposed and reputed embryological mechanisms for the various dysraphisms. And I emphasize these are all reputed because really, other than myelomeningocele, for which there's really good experimental evidence of a failure of neurallation, localized failure of neurallation, and anencephaly, similarly, all the other occult dysraphisms, the embryologic mechanisms are really reputed. None of them has proven. There's really not a lot of animal models for them. And that's one of the beauties of being interested in this field, is I can propose just about anything and nobody can disprove me. When we talk about early embryonic development, we begin with blastogenesis, right? There's about 5 rounds of cell divisions, which gives rise to a 32 cell blastocyst. And then that blastocyst forms into a sphere with a group of cells that are all packed up against one side of the sphere, called the inner cell mass, and the cells around it are the blastocystic cavity. The next thing that happens is that this inner cell mass further develops into a 2-layered structure containing an epiblast and a hypoblast. The epiblast is adjacent to the amniotic sac, which forms between the epiblast and the adjacent trophoblastic cells, which are going to form the placenta. And the yolk sac, or umbilical vesicle, is adjacent to and underlies the hypoblast. And the last thing I want to discuss with this is that there is the very beginnings of a rostrocaudal organization, where the prochordal plate becomes thicker here at what's going to become the cranial end of the embryo. The next thing that happens is gastrulation, and that's a complex process And I just want to introduce you to a couple of concepts. Initially, as we said, the embryonic disc is composed of an epiblast and a hypoblast. The hypoblast cells actually will be displaced and become extra embryonic tissues. What happens during gastrulation, and the reason this happens, is that the primitive streak here, which is formed initially at the caudal pole of the embryo, and then over the course of time becomes elongated, reaches its maximum length, and then begins to regress back down toward the caudal end of the embryo. And that primitive streak is composed of cells that are migrating from the epiblast toward the midline, and they dive through what's called the primitive groove here. The first cells that come through from the epiblast displace the hypoblast cells out laterally and replace them with definitive endoderm. The next cells that come through from the epiblast will migrate between the newly formed endoderm and the epiblast, and they'll form the mesoderm, which gives rise to everything, remember, except for the skin, the nervous system, and then the lining of the GI and pulmonary epithelium. So they'll give rise to bone, muscle, cartilage, blood vessels, and so on. And the last cells of the epiblast that remain spread out to replace all the cells that have migrated through the primitive streak, and they form the definitive ectoderm. So gastrulation converts the embryo from a two-layered structure containing epiblast and hypoblast to a three-layered structure having ectoderm, mesoderm, and endoderm. I would draw your attention to the very end of the primitive streak, which is called Henson's node, this U-shaped structure that caps the cranial end of the primitive streak. That's a specialized structure, and it contains prospective notochordal cells. And during particularly primitive streak regression, as it gets shorter during that second half of its life and migrates back down toward the caudal pole of the embryo, the prospective notochordal cells are laid down between the ectoderm and the endoderm right in the midline. And they come to underlie the central or the neuroepithelium, which is the remaining cells of the ectoderm. And the prospective notochordal cells migrate down through what's called the primitive pit, which is the cranial extension of the primitive groove. And of course, the notochord ultimately will involute and form the nucleus pulposus of the intervertebral discs, as we know. The next thing that happens, and this is restricted to primate embryos, including humans, is that the notochordal process, which is initially formed, undergoes a strange configuration change. This is now a quarter of an embryo with half of Henson's node here, the primitive pit right in the midline, the primitive streak would be down here. And initially, as the notochord is formed, it's hollow. It has a notochordal canal in the middle, and these cells are radially arranged around this lumen, this central lumen. And what happens is that during embryogenesis, the notochordal process fuses with the underlying endoderm and thereby opens up the notochordal canal to the underlying yolk sac. And for a brief period of time, usually about 3 days, the amnion, which is of course above the ectoderm, is in direct communication with the yolk sac beneath the embryo through this primitive pit, which is now called the Narenthiran canal. About 3 days later, the notochordal process rolls up again. And by the way, this is called intercalation. 3 days later, the notochordal process rolls up and separates from the underlying endoderm and becomes the true notochordal process. And that process is called excalation. The next process is primary neurallation, which occurs during the 3rd and 4th weeks of embryogenesis. And it begins with the thickening of the neural plate, neuroepithelium here. And overlying the notochord, there is a groove that develops because of conformational cells that are blocking on the word now, but the notochord causes these cells to become wedge-shaped and creates this wedge or median neural fold. The neural folds, median groove, neural groove. The neural folds will then elevate around this central line here and begin to converge A similar process of conformational cell change in the lateral neuroepithelium causes a bending of the neural folds toward each other. So they elevate, and I tell people it's sort of like elevating your arms from your shoulders and then bending your elbows toward each other. The secondary hinge points, we call them, produce this bending here of the neural folds toward each other. Of course, the neural folds are still connected. This is a critical piece of information. The neural folds are still connected at this point to the lateral cutaneous ectoderm, which is going to form skin. So you can see the cutaneous ectoderm here, laterally connected to the neural folds as they elevate and converge. And the last thing that happens is that the neural folds will meet in the midline, they'll fuse one with another, and at the same time, the cutaneous ectoderm separates from its attachment to the neuroectoderm and fuse across the midline to form the dorsal skin overlying the neural tube. And then, of course, the somatic mesoderm comes in and forms the neural arches or the bony arches of the vertebrae and so on. The neural crest cells, just a moment, just take an aside here. The neural crest cells, as we know, migrate out. They're highly migratory cells, and they contribute to a whole bunch of different things. Most important are the dorsal roots and the dorsal root ganglia from the standpoint of today's discussion, but they form a lot of other things as well. And the first points of attachment where the neural folds come up and meet is typically in the cervical spine or the lower medulla, somewhere around the cervical medullary junction. And then it meets there and then it propagates and closes. And it used to be thought that there was one zipper that went up and over the top of the head and another zipper that went down the back. It's probable, and in mouse embryos, it's been shown that, actually there are several waves of neural tube closure. And the points where these waves migrate and meet one another constitute the last areas of the neural tube to close. And these are the neuropores. And the most important are the caudal neuropore, which we'll talk about in a second, and the cranial neuropore. The cranial neuropore actually is at the level of the lamina terminalis. That's the adult site of the cranial neuropore and near the commissural plate. The caudal neuropore is the S2, or the second sacral spinal cord segment. And you'll see some embryology texts talk about L2, that's incorrect. It's the second spinal cord segment. So all of the tissue down to and including S2 is formed by this process of what we call primary neurallation. Anything caudal to S2 is derived from secondary neurallation, which is a different process. Secondary neurallation begins near the end of the 4th week. These cells are the cells that remain at the caudal pole of the embryo as the primary neural tube is closing. And near the end of the primary neurallation, these cells are initially exist as cells that are radially arranged around a central lumen. These various little tubules, if you will, begin to fuse one with another to form larger tubules, and eventually those all fuse with the primary neural tube over this junctional or transitional zone, which we'll talk about a little bit in a second. There are some interspecies differences, which I won't get into in the interest of time, but this is probably, which is in chick embryos, this is probably more akin to human neurallation. This junctional or transitional zone where there's overlap between the primary and secondary neurallation is a rather unique area, and it's recently become better described. It's a unique segment of presumptive neuroepithelium located in humans, we think, at about the thoracolumbar junction. And it flanks Henson's node and the upper part of the primitive streak, these neuroepithelial cells. And there are actually two discrete groups of these cells that are molecularly distinguishable. There's a lateral group, which expresses the SOX2 gene, and those groups of cells migrate dorsally and will form the neural folds. The medial group, which expresses SNAIL2, NCadherin, and BMP4, and initially doesn't express the SOX2 gene, they're different cells, and they migrate caudally and ventrally, and they're the cells that are going to form the secondary neural tube, and they also contribute to the ventral portion of the primary neural tube over this junctional zone. So the primary neural tube is more dorsal, the secondary neural tube is more ventral, and that junctional zone is a unique area that may play a role in some of these different dysraphic malformations. And this is just a diagrammatic representation of this. The cells that form the neural folds here and express, these are the dorsolateral ones that express SOX2, and then these ventral group here, which are going to contribute to the secondary neural tube. The last thing I want to talk about in terms of normal embryogenesis is ascent of the conus medullaris. This begins on embryonic day 42 and continues even after birth. And there are two distinct processes. So between days 42 and 53, there's this process called retrogressive differentiation. The cells of the caudal neural tube undergo a de-differentiation, if you will. The caudal neural tube becomes thinner. There's no well-developed cellular organization to it, and it looks, quote, looks less well-developed. This is from the papers that have studied this, not very well, I might add. Beyond day 53, retrogressive differentiation is completed, and so that process no longer is working, and the rest of the ascent of the conus occurs by differential growth of the spinal cord and vertebral column. So by day 54, what you're seeing is that the spinal column is getting long, the spinal cord is getting long, but it's getting long short, or it's getting longer to a smaller degree than the adjacent vertebral column. And so that leads to this progressive discrepancy between the neural level, spinal level, and the bony level. And of course, that leads to the ascent of the conus medullaris and the cauda equina, where the nerve roots are actually traveling down before they get to their exit zones at the various vertebral levels. That's due to the progressive stretching of this. And you can see this depicted diagrammatically here. Initially, the spinal cord is very low and then begins to ascend. And of course, ultimately it gets to its adult resting place. And we'll talk about that, where that is in just a second. But and then the cauda equina nerve roots come down to exit via their original locations, where they were early in embryogenesis, adjacent to that part of the neural tube. This ascent of the conus medullaris occurs almost exclusively, if not exclusively, prenatally. There's some question about whether or not it continues for the first 2 postnatal months. Again, not years, as some textbook would suggest, but 1 or 2 months postnatal. This is a depiction from Barson's original paper, and you can see most of it occurs during the first trimester. Here's term here, and the rest of it goes up until term. In his paper, it was at the L2-3 disc space by birth and rose during the first 8 weeks postnatal, 2 months postnatal, to its adult level opposite the L1-2 disc space. Anything below the middle third of L2 is generally considered to be radiographically tethered. And you can see how you would you can figure out where the conus is, both on axial MRI images and on sagittal images here. And we did a study on 100 children here with brain tumors who were undergoing screening whole spine imaging, which sort of eliminated the issue of we could count down from the top and count up from the bottom to make sure we were counting the right levels. And of course, none of these children were being imaged because they had symptoms of spinal cord tethering. And so what we found was that the mode was the L1-2 disc, the mean was the inferior third of L1, and the lower limit of normal, the most important part from our discussion, is the middle third of L2 within 95% confidence limit. So anything below that level, that middle third of L2, should be considered radiographically tethered. That doesn't mean they're symptomatic, but at least radiographically, they're outside the norm. And of course, this leads to the whole concept of clinical tethering. And Shohei Yamada, in a series of very elegant experiments between 1981 and 1995, did a number of these studies on cats and in humans, and basically demonstrated that tethering, stretches the spinal cord. That stretching results in decreased blood flow that in turn leads to decreased glucose metabolism, a shift to anaerobic metabolism, and changes the oxidative state of the cells. So with that as background, I want to just shift gears and talk about dysrapism embryology. The traditional classification divides these things into open and closed malformations, as I'm sure you've been taught. The open malformations, myelomeningocele is the most common, and there are a number of others. We'll talk about, hopefully, combined anterior and posterior myelomeningocele, or the split notochord syndrome, which is a fascinating condition in just a minute. And then closed malformations, which include lipomyelomeningocele, split cord malformations, dermal sinus tracts, thickened phyla, myelocystoceles, and so on. What Michael Partington, a good friend of mine, a pediatric neurosurgeon now in Kansas, and I really started to talk about way back in the 90s, was to really think about these things in terms of their reputed embryologic mechanisms. So we can speak about disorders of gastrulation, which, at least from my perspective, includes split cord malformations and all of their variants, a failure of neural tube closure, primary neural tube closure, which of course gives rise to myelomeningocele, anencephaly, and perhaps to hemimyelomeningocele. Disorders of disjunction, that separation of cutaneous and neuroectoderm at the final stages of neural fold closure. And you can divide those into premature disjunction, which according to Dave McClone, proposed that a long time ago that this gives rise to spinal lipomas, and failure of proper disjunction, which gives rise, we think, to dermal sinus tracts, dermoid tumors. And I'd like to propose that Meningocele Monkey, meningoceles themselves may be different other manifestations of this, as I'll demonstrate in just a minute. And then disorders of secondary or junctional neurallation, terminal lipomas, myelocystoceles, sacralogenesis, Curino's triad, and perhaps even sacrococcygeal teratomas. And then post-neurulation disorders. Meningoceles have been classified as post-neurulation disorders. I put a question mark there because as I'll demonstrate, I think they may represent disorders of disjunction, actually. Encephaloceles have traditionally been thought to be post-neurulation problems, and of course, Chiari malformations. So let's start with myelomeningocele, which represents, this is the easiest one to understand. It's a localized failure of primary neurulation, right? The neuroepithelium didn't properly close to form a tube. And so the malformation is by definition open. That is, there is no such thing as a closed myelomeningocele. And those things that we call closed myelomeningoceles are really myelocystoceles. The spinal cord is exposed as a placode somewhere on that in that malformation on the skin, because the neural tube didn't close. The edges, the neural folds, are still connected to the cutaneous ectoderm. They've never separated, and so by definition, it has to be an open malformation. They're circumferentially attached to the skin, and spinal fluid leakage is variable. I do want to comment on the issue of myelomeningocele versus myeloschisis. Dave McClone taught me way back when that these really shouldn't be different names for things. They differ really only in the size and the extent of the underlying CSF collections. Myelomeningoceles have that seal, which is the fluid collection that elevates the spinal cord or the placode on a dome of fluid. Myeloschisis, as you'll see in the next slide, basically is a flat malformation. But really, the underlying embryonic process is the same. The neural folds fail to converge and fuse across the midline. And so we should probably discard these terms. And here's just a bunch of examples. And you can see here's the placode sitting on this and attached to this dysplastic skin. In this child, this is quite a large cystic mass. Here's one that's flat, or relatively flat. And again, neural fold, you can actually see the midline neural groove still here in this fold, and as you can in many of these, attached circumferentially to this dysplastic skin. Here's another one. Again, the placode sitting here with the neural groove and this dysplastic skin around it. And here is what we would consider to be a myeloschisis according to the traditional part. And you can see this open neural tube here, again, with the neural groove in the middle. and it's connected just outwardly to the dysplastic skin circumferentially. This is all part of the neuroepithelium that's just been thinned out. Spinal lipomas are skin-covered malformations, as we know. 85% of them have a large extradural component, are visible on the back, but 15% may be totally intradural and may have no cutaneous manifestations whatsoever. They're the most common occult spinal malformations, representing about 20 to 50% of occult spinal dysraphism and about a third of skin-covered lumbosacral masses. And importantly, the fatty stalk, as we'll see in a second, lies dorsally and medially to the dorsal root entry zone, or the DRES. This is important and is predicted by the mechanism that Dave McClone initially proposed for these malformations, as we'll see in a second. So here's a classic spinal lipoma. Note the salmon patch or Phlameus nevus over the top. And this is a nice slide in that it demonstrates the relationship of the fat to the dorsal root entry zones here. These are the dorsal roots coming in, and the fat lies dorsal and medial to those. And from a surgical perspective, that really gives you a lot of orientation as to where the fat is located versus the spinal cord. And that's really, I think, the beauty of Dave McClone's proposed mechanism, even though I think it probably is incorrect and certainly doesn't account for the terminal lipomas that can't involve primary neurallation and instead involve some element of secondary neurallation. So his proposal, or his hypothesis, was that there was premature disjunction as the neural folds are closing. This allows mesenchymal cells to enter into the central canal, where their fate is, they differentiate, their fate is changed to form fat cells, which you see here within the spinal cord, rather than the pia arachnoid, which they would ordinarily form if they stayed outside of the neural tube. And so you have this fatty stalk. And remember, as I said, the neural crest cells here are arising from the edges of the neural folds right next to their attachment to the cutaneous ectoderm. So these neural crest cells, when they migrate out, are going to form the dorsal roots and the dorsal root ganglia. So you can see why the fat in here in the central canal, the spinal cord, lies dorsal and medial to these dorsal roots. And again, it's a very nice anatomical point when you're resecting these. Shifting gears, I want to talk about dimples. First of all, innocent coccygeal dimples. Innocent meaning they're benign, they are of no consequence. Coccygeal is very important. These are coccygeal dimples. They're not sacral dimples. They are within the gluteal cleft. They're usually within a few millimeters of the tip of the coccyx. The gluteal cleft is generally normal. The dimple is shallow, non-complex. It doesn't have tufts of hair or other things sticking out of it. And these children generally are normal and they don't have any problems. This probably represents the remnant of Henson's node as it gets way down toward the coccygeal end of the embryo, where it is called the tail bud now. This is probably the remnant of Henson's node. These coccygeal dimples are present in up to 4% of the population. They're not related to pilonidal cysts in adults, and there's no convincing evidence of any causal relationship to dysraphic malformations. And I point you, I listed a number of papers here. Weppern and Oakes is the classic, over 1,000 cases with no evidence of any tethering or deterioration in any of them. Although imaging, I should say, wasn't done. And so we don't know what they look like under the skin, but all of them were benign. And this is just a picture showing a benign coccygeal dimple. This dotted line is where the gluteal cleft, or the buttocks cheeks would be. And you can see my fingers separating those. You have to separate the buttocks cheeks to see that dimple. And it's usually within a few millimeters. If you put your finger on it, you can roll it around the tip of the coccyx. So these are coccygeal dimples. And if you were to get an MRI scan, which is not recommended, but if you were to get one, you would see that the tract goes all the way down to the tip of the coccyx, unlike the sacral dermal sinus tracts, which are farther cranial. And we'll address those in a second. Just a little brief note. These are what I call tweeners. The in-between ones, strange-looking buttocks, cracks, multiple dimples here. I have imaged all of these, and I continue to do so because I don't think we have a large enough number of them to be able to say definitively that they're not pathological. But I've imaged all of them. I've not yet found any underlying dysraphic malformations in them. Spinal dermal sinus tracts have an incidence of 1 in 2,500 births, and they are, most of them are lumbar or lumbosacral. They may be associated with other congenital spinal cord malformations, particularly lipomas, but also thickened phylum, endodermal or dermoid cysts. The dermal sinus tracts are, the spinal ones, are above the gluteal cleft, so they're lumbosacral, not coccygeal. And the gluteal cleft very often is abnormal. They're deeper complex. They may have tufts of hair, hemangiomata, appendages, or skin tags, and these patients eventually become symptomatic from those. So here's a group of them. Here's a strange-looking buttocks crease with this dimple with a surrounding little salmon patch here outside of the gluteal cleft. Here's another one right at the end of the gluteal cleft off to the side. Here's a strange looking gluteal cleft, and I point your attention to this little guy up here, which has a little skin tag and multiple hairs and a little flameus nevus around it. Here's another one with a dermoid within the skin right at the top of the gluteal cleft. Here's one that's closed. We don't see. So this whole adage that if you can see the bottom of the dimple, it's not pathological is completely untrue. Here's another one with a scab on it. So yes, we know that the deterioration from spinal dermal sinus tracts comes from multiple mechanisms, including spinal cord tethering, bacterial meningitis. They serve as a portal of entry for meningitis and other infections. Aseptic meningitis because of desquamation of epithelial debris within the CSF, and mass effect from an expanding dermoid inclusion cyst. So any of those mechanisms can be in process or in play from dermal sinus tracts. And the embryology of these seems to be a failure of the neuroectoderm to completely separate from the cutaneous ectoderm during that process called disjunction. And so that leaves a tongue of cutaneous ectoderm attached to the neural folds, which then become the neural tube, and they drag that tract down with them. And the persistence of the tract can be variable. I've had very, very, very few of these that involve the subcutaneous tissues only. The vast majority of them remain attached to the spinal cord, and their most common attachment is to the posterior neuropore at S2. Now it's the S2 spinal cord segment, and I'll show you in just a second. But this is predicted by the embryologic mechanism, right? It's a primary neurallation disorder. And so S2 is the lowest part of primary neurallation. It's also the most complex part of primary neurallation geometrically. And so this tract ends along the dorsum of the spinal cord at the level of S2, and generally is separate from the phylum terminale, which you would expect because the phylum is formed by secondary neurallation, not by primary. Oops. So here it is diagrammatically. You see the spinal cord and the skin attached. There's failure of disjunction. This drags this tongue of cutaneous ectoderm down, where it becomes a tract, sometimes associated with a dermoid or epidermoid tumor or cyst. And this is what it looks like in a newborn. Here's the tract, here's the skin dimple, and you can just make out this slight, it's very subtle here, but it comes up and attaches here to the dorsum of the spinal cord, and the tip of the conus is down here. This is ending somewhere above the tip of the conus. So it ends at the end of primary neurallation, and that tip of the conus below and the phylum are the parts that are formed by secondary neurallation. So if we excise these, we make a skin incision, we ellipse around the dimple, we follow it down to the lumbodorsal fascia. That's been resected here or dissected, and the tract goes down usually between two spinous processes and invades the interspinous ligament here. There's the lamina there. Once we do our laminectomy, we can follow the tract down toward the dura, where it enters typically just below where the skin lesion is, or slightly cranial to it. Once it gets into the dura, it travels up intradurally, and it ends on the dorsum of the spinal cord. Here's the conus. Here is the phylum, separate from the dermal sinus tract. So when we fix these, we need to go to the junction of the tract with the spinal cord, dissect it off the top here and remove it. But we also need to cut the phylum as a separate point of tethering. And here's after that's been done. I just want to momentarily talk about the cranial end, which is also, we know about them, but a lot of people don't. A lot of primary care pediatricians and primary care docs really don't know about these. These are less common than their spinal counterparts. They can be occipital, nasofrontal. I actually wrote a paper with one of the folks from, one of the neurosurgeons, pediatric neurosurgeons from Tehran, about bilateral retroauricular dermal sinus tracts. And again, these can cause deterioration, not by tethering, but by serving as a portal of entry for intracranial infection or growing intracranial dermoid or epidermoid masses. The occipital ones are obviously at the occiput. The pit is usually located near the occipital external protuberance. Skull x-rays and CT scans demonstrate both a bony defect and a tract typically. The MRI obviously better demonstrates the tract. There's invariably intracranial extension. And as you see in this one small series, hairy nevus was present in 2 of 8 cases and a subcutaneous mass in half of them. So here's a case of a child from actually originally from Pakistan. And you can see it, we've shaved him, but this had very strange looking hairs coming out of it. His brother was a medical student at Cornell at the time. And I asked him what his now 16-year-old brother, what that looked like. And he said, I remember when he was a baby, he had these strange black hairs coming out of the back of his head, and we didn't know what those were. Here is the MRI scan, the sagittal showing the defect here, and a large, this turns out to be an epidermoid. You can see it on the ADC map here. This is, of course, how we differentiate these from CSF collections. And you can see the tract coming in here. The frontonasal ones are rather innocuous dimples located anywhere between the nasal tip and the glabella. The tract will extend between the nasal bone and the nasal cartilage, and I have a picture of that in just a second, toward the anterior skull base. 90% of them, fortunately, end before they get through the skull, but 10% will extend through the skull, where they extend through the frontonasal suture, through the foramen cecum at the base of the anterior fossa, anterior to the crista galli. And there are a few cases that have shown that they actually will, they rarely do this, but when they do, it's fascinating from an embryological standpoint. They go through the dura, and they out the posterior leaf of the anterior falx, and then they end up attaching to the lamina terminalis, which is, of course, the anterior neuropore. And here's a couple of examples. This one, an adult here. Here's a child with one on the right at the nasal root here. MRI scans disclose, or CT scans disclose a widened area here, often with a little tract defect in the bone. And on MRI scan, you can see the tract coming in through the foramen cecum right at the bottom part of the frontal bone here. Here's a child with an inflamed one, and you can see the crusting, and this had a little bit of leakage of yellowish fluid. And here's his MRI scan, again, showing this tract going up into the inferior and part of the anterior fossa. And this would be the lamina terminalis somewhere around here. And so those rare cases will come up and insert or attach onto the lamina terminalis. The embryology of these, failure of disjunction at the cranial neuropores. Here's a depiction. This is the normal anatomy here with the frontal bone, the nasal bone, and the nasal cartilage. These can come in through the fonticulus nasofrontalis between the frontal bone and the nasal bone, or they come up through the prenasal space to gain access to the foramen cecum here, where they extend intracranially. And as I said, they can go through the anterior falx in the dura and along the anterior skull base and end on the lamina terminalis, which stretches between the anterior commissure and the optic chiasm. And this is what it looks like at surgery with this tract coming in. Here's the anterior dura. My plastic surgery colleague actually injected this with a dye. We don't use this particular dye anymore, but you can see that it goes into and it extends into the subarachnoid space here in this one. Meningocele Monkey, likely related embryologically to the dermal sinus tract. These are lesions that have a scarified or cigarette paper or cigarette burn skin lesion, and they may be very tender to touch. There's no CSF leak, and what they have is a collection of peripheral nerve elements that go up and attach to the undersurface of this malformation. So this has peripheral nerves and sometimes dorsal root ganglion cells. And 50% of these are associated with split cord malformations, which we'll talk about in a second. And here's what they look like here's what they look like with this scarified cigarette paper sort of thing, often with a collar of dysplastic skin around them. Here's another one. And I think that these probably represent another disorder of disjunction where the neural elements lost the battle and the cutaneous ectoderm pulled a piece of the neural crest cells out with it. And those neural crest cells, of course, formed peripheral nerve elements and dorsal root ganglion cells. So similar to the dermal sinus tract, but in the opposite direction. And here's an example of a Meningocele Monkey with that stalk of tissue going up to the skin. And then spinal meningoceles, which we've always thought have been post-neurallation disorders, are isolated CSF containing sacs with, quote, no neural elements, right? We all have been taught that. And that we thought that these were a mesenchymal insufficiency with extrusion of spinal fluid that sort of pulsated out and formed a skin-covered sac, but there was no spinal elements in it. But what I found in doing these, I appreciate anybody else's comments, when I've been carefully removing these, I cut along and I elevate I cut along one side, elevate the sac and look carefully within it. And what I found, here's what they look like, right? This fully skin-covered mass on an MRI scan. The spinal cord remains in the sac, and we don't see anything visible that connects the spinal cord to this mass. And so we think that this is just a bunch of CSF. But when I've done it, and I apologize for the blurriness of this, but when you elevate the sac and look carefully inside, what you see is a tract of tissue that goes from the dorsum of the spinal cord up and attaches along the inner border of this, the dural layer, meningothelial layer of this sac. And so again, I think that these are disorders of disjunction where there's a fibrous band of tissue that may have neural elements, it may have peripheral neural elements from neural crest, and it may even have cutaneous elements within it. But yet another manifestation of disordered disjunction. And here it is after this fibrous tract has been sectioned, and you can see it's, again, this is the filum terminale. This is along the dorsum of the spinal cord at the level of about S2. So very similar to the dermal sinus tracts. Split cord malformations. Dr. Pang brought these to our attention. I was a resident of his and became very interested in these. The spinal cord, of course, is split over a portion of its length, and the two hemichords can remain separate all the way down, in which case they're two phyla, or they typically merge back together again, and then there's a single caudal spinal cord and one phylum. It used to be thought that they divided these into diplomyelia and which they thought was a separate thing, and diastomatomyelia. But it turns out that each hemichord displays functional lateral dorsal and ventral nerve roots. So the lateral aspects are the things, those are the nerve roots that come out and go to the limb. But there are variable numbers of non-functional atretic median nerve roots or medial nerve roots that end within the cleft between the two hemichords. Most commonly, these are dorsal, but I've seen two occasions where there are ventral roots as well. And this is a case that I had, unfortunately, the child actually passed away. But at post here, we got permission to look at the spinal cord. He had a known split cord malformation. And here is this big bony spike between the two hemichords. And you can see it's not a half a cord. there's a well-developed lateral cord, and in this case, almost complete medial cords as well. And we are able to demonstrate actually nerve roots, both ventral and dorsal, coming from each of these hemichords and projecting toward this bony spike in the middle. As you know, Dr. Peng divided these into two types: the type 1, in which the spinal cord, again, is split over a portion of its length with both lateral and variable atretic medial nerve roots, with each of the spinal cords is contained with its own dural sheath. I tell people this is like pants, legs in a pants. So you have the leg, which is the spinal cord, and the pants, which are the dural tubes. And there's an intervening extradural bony or cartilaginous septum. So I'm sure you've seen these pictures like this with the two dural sacs with the white CSF and the gray hemichords within each of them, looking like owl's eyes, with a bony spike extradurally between them. And you can see it on CT scan as well. And this is from Dr. Peng's collection, showing this bony spike here with, and what you don't see here very well is that this lies extradurally, and then there's this cuff of dura around the bony spike. And by the way, these can be dorsal, but about 10 to 15% of them can also be ventral. And there can be multiple of them. About 15% of these have tandem lesions at different points within the spinal cord. So you need to image the entire spinal cord to see these. Type 2 split cord malformations, the same as type 1, except that they're enclosed within a single dural sheath. So I liken this to a dress, two legs contained within a skirt, with an intervening intradural fibrous band. Remember, we used to think that there was nothing tethering these. Radiographically, you couldn't see anything, but at surgery, you can see these tethering fibrous bands together with median nerve roots that attach this and tether the spinal cord. Here is another example with a whole leash of these atretic median nerve roots forming basically a Meningocele Monkey. These are passing through the dura and up into the extradural space here, but they're non-functional. And what I noticed when I was a fellow with Jack Walker is that I started doing a literature search that split cord malformations are associated with a variety of other malformations. And they're malformations that involve all three of the primary germ layers: ectoderm, mesoderm, endoderm. So if we look at ectodermal malformations, a variety of them have neuroectodermal malformations. Of course, the split cord is the primary neuroectodermal malformation, but the myelomeningoceles, up to 40% of them can have an associated split cord malformation. Hemimyelomeningocele is a classic split cord malformation with one hemichord failing subsequently to neurallate. And so it ends up as the placode, which is slightly off center with asymmetrical paralysis. The other intact cord rotates underneath and travels under the band between those two hemichords. And then cervical myelomeningocele, which is fairly uncommon, but we reported on a number of these many years ago. This is what they look like. They're fully skin covered. They don't leak CSF. This is in the nape of the neck. They have this band of tissue that goes within the meningocele sac, and it goes down to 50% of our series were associated with split cord malformations. And this had both central nervous system and peripheral nervous system tissue within it. So it technically was a myelomeningocele, but it's a very different kind of myelomeningocele. We also know that there are cutaneous ectodermal malformations with split cord malformations. Of course, the most common is the hairy patch, right? The fawn's tail, or the hairy patch, which is 20 to 55% of these cases, typically the type 1s. But there are a number of other skin malformations that you can see as well. Here's the example of the hypertrichosis. And then there are mesodermal malformations, vertebral or somitic malformations, right? Fused vertebrae, sagittally clefted or butterfly vertebrae, hemivertebrae, missing vertebrae. Of course, a widened interpedicular distance is important when we talk about the embryology of these in a second. Spina bifida occulta, and of course the midline bony septum or the midline fibrous bands between the two hemichords, right? So this is an example of different vertebral malformations. But we also can have urogenital mesodermal malformations. This is the intermediate mesoderm rather than the somatic mesoderm. And you can get associated unilateral renal agenesis, horseshoe kidneys, bladder duplications, double ureters and double urethrae, bicornuate uterus, double vagina, and even double penis or double clitoris. And so there's this duplication that we see in association with these split cord malformations from a urogenital standpoint. And then endodermal malformations, of course, neuroenteric cysts are the most common that we see, but we can see enteric duplications, fistulae, malrotations, Ladd's bands. Combined anterior posterior spina bifida is the most severe of these. And the hindgut duplication sequence, where the entire hindgut, the colon, rectum, anus, and variably the urogenital system are duplicated in association with these split cords. This is a spina bifida, very rare malformation. You see the sac on the back of the infant, but when you look, I covered it up here, but this actually is, you see there's no bowels, bowel loops in the abdomen. They're all within this sac. And so everything from the enteric system is actually herniated through a hole in the spine, and you can see the vertebrae traverse around this hole, and the entire enteric system has a connection with the back, with the infant's back. And here's an MRI scan showing this kind of semi-duplication of the vertebrae with this tract between it. There have been a number of embryogenetic theories proposed. There was a proposal that the ectoderm and the endoderm were fused, and so they couldn't come apart during early neurulation. Accessory neuroenteric canal theory by Bremer, where he thought there was another neuroenteric canal that connected the amnion to the yolk sac through the embryo, a hole in the embryo, just like the primitive neuroenteric canal. Saunders proposed a notochordal duplication sequence. And when I was a fellow, Jack Walker and I published this rather obscure paper talking about anomalous midline axial integration during gastrulation as a new and novel theory. What we proposed was that the Hensen's node and the primitive streak were abnormally wide, maybe because there's an incomplete basement membrane here or some other reason. We certainly couldn't tell why, but this gave rise to two independent heminotochords, and of course then that induces the overlying neuroectoderm to form two hemichords. So we thought that this was a problem with gastrulation even before neurulation had occurred. And by the way, if you presented now two neural tubes, one of them could fail to undergo primary neurulation, which happened subsequently, while the other one neurulated successfully and remained underneath. Finally, I'll finish up with caudal malformations, abnormalities of the caudal cell mass or disorders of secondary neurulation, sacral agenesis, myelocystocele, Carino's triad. We all know that these are associated with a variety of anorectal malformations, the most egregious of which is cloacal exstrophy, and they're more common in infants of diabetic mothers. Terminal myelocystoceles, we have a sac within a sac, right? The spinal cord trumpets out and is contained within a larger dural sac with the intact skin overlying it. Here is an example of that with the cloacal exstrophy, the prune belly having been repaired already in this infant. This is the MRI scan showing the sac within a larger sac and typically a lipoma associated with that. This is from Dr. McClone's paper, diagrammatically showing that with the lipoma, the trumpeted out central spinal cord with the surrounding dural one as well. Human tails and pseudo tails. The difference between these two really is arbitrary and is not helpful because both of them are associated with dysraphic malformations. You can see a variety of these. They often have a little tract that goes down. Here's an MRI scan showing the tract. Here's one that's been excised. You can see the tract going down to the dura caudally. And then after I open the dura, the tract actually becomes the filum terminale here. This is the end of the spinal cord. And then I'll end up with the thickened filum, greater than 2 millimeters on myelography or on MRI, often containing fat density, conus ending below the midbody of L2. a question of whether this represents an embryological disorder of secondary neurulation or even retrogressive differentiation. I don't think we know the answer to that. And there's an MRI with the fat, and here is the phylum here, as we all know, containing fat with the conus up here more cranially. And for more information, you can, as Naren said, you can look at this book, Embryology of Occult Spinal Dysraphisms, which is a great book, irrespective of the fact that we wrote, Dr. Rizek and I wrote the embryology chapter for it. So you can certainly look at that. And I will entertain, I guess we have maybe 5 minutes for questions.
Thank you very much, Dr. Dias. That was a fascinating talk covering the whole spectrum of dysraphisms, and it's a complex area, and trying to understand it from embryological point of view is the way to try to tackle it, and it really was a feast. First of all, questions for Dr. Dias. Anyone has questions, you can put your hands up on the chat box or on the by your the box, or you can just type it. Dr. Dias, can I just ask you two simple questions to start off with? In terms of the coccygeal sinus tracts, have you ever had to operate on them at all?
I probably inadvertently early in my career operated on a couple of them that I thought might be pathological. And I have to say they were a huge disappointment. They went down, I followed them, and they just petered out. And so when I say I've had a couple that I have that have not attached to the skin or to the spinal cord, I think those were probably early in my career and were coccygeal dimples before I really sorted all of this out in my own mind. I don't recall any, I've not operated on any of the true, what I consider to be true coccygeal dimples since very early on in my career. All of the sacrococcygeal dimples, I'm sorry, all of the sacral or lumbosacral true dermal sinus tracts I've operated on absolutely go all the way down into the dura and attach to the spinal cord, every single one of them.
Thanks, thank you very much. The other question I wanted to ask you was, in terms of, I think when we had your lecture on open myelomeningocele, I did ask, and I think I know the answer, but for the general, for the participants as well, when you repair the open myelomeningocele, knowing where the plug cord ends and your, what you call your dysplastic skin starts, where do you divide? What's your rule of thumb? Is there a way that you can be absolutely sure? Because that's the main point of that operation, isn't it?
Yeah, it is. It's critical to get off the cutaneous elements. And so I usually, if I go back to, let me just go back real quick to the myelomeningocele one. So what I do is anything that has any cloudiness to it, I consider to be skin. And so I stay inside of that border. So here, on this side, I would come inside of this area here. And so I stay just inside of that area. Again, here, just inside of that area where the skin sort of has that opalescent or silvery, in a lot of cases, a silvery appearance to it. And then once I have it all completely dissected free, I go around and make sure that there's nothing that I can see that I think would be suspicious for cutaneous ectoderm, and take those little bits off. The hardest ones, I think, are the ones where the placode really comes all the way up to the skin, and there's not this nice thin area where you can just take a knife and cut into it, and it's a very thin, almost like a cellophane area. In some of these, it's very thick right at the edge. And of course, the dorsal roots are coming off right near here underneath, because they're right at the neural folds, right where it attaches to the skin. So those are the most dangerous ones. And you just have to be careful you don't pick off the dorsal roots as you do that.
Thank you. There's a question from Dr. Maurya. Dr. Maurya, do you want to introduce yourself and please ask Dr. Dias your question? Thank you.
Hello, sir. Hello, Professor Dias. I'm Dr.
Yes, hi.
Ved Prakash Maurya, sir. It's a very interesting talk. First time I come to listen from you. Just now I came from my operation room and I operated a ruptured meningomyelocele kid, 11-month-old. So, hello, sir.
Yes, I hear you.
Yes, sir. My doubt is what we have to do with the dystrophic nerve roots and the part of the placard which is adhered to the meningomyelocele sac. Because after dissecting the sac, a portion of the placard was adherent to the sac. I disconnected from the sac. Now there was very less space to put it back in the dural tube. So it was a very practical dilemma for me. My resident was saying, you cut it off, sir, it's useless, I don't know. And unfortunately today my electrophysiology system was not working. So I somehow managed to put it back and close the dura and close the wound. Post-op child was very active, no deficit. But there is a query in my mind. So it was a very appropriate time to ask you. Just 1.5 hours back, I operated on that kid. So can you...
We've argued about this in the National Spina Bifida Patient Registry, the NSBPR, which is you may know, is a multi-institutional consortium funded by the Centers for Disease Control in the United States. And we're amassing quite a large database of now, I think we're up close to 7,000 patients with myelomeningocele and other lipomas and split cord malformations in thickened pili. Not all occult dysraphisms, but different parts. And there's a big discussion among us about whether or not to do what we would refer to as placodectomies for those patients, particularly for those where there's no lower extremity function. And so kind of the ultimate untethering. And Leland Albright, who I also trained with, was somewhat of a fan of doing that. And he published a paper several years ago showing that it seems to work well. The data is mixed. There are a couple of papers that suggest that perhaps as many as 15% will lose, and this is from the orthopedic literature, will lose or worsen in terms of their urological function and become completely incontinent, kind of dribbling continuously rather than having a reflex bladder. And that's really the most problematic, right, concern we have. So I would say, in general, I try to keep the placode intact and not cut it off. But
Yes.
Been discussion among us of actually generating a study to, if we could get equipoise, to have people either resect the placode or not. There's actually some data to suggest that it may improve bladder function and eliminate that upper motoneuron spastic bladder, which of course is what causes so much of a problem for the kidneys. But you don't want to do that at the expense of continuous dribbling, right?
Okay, sir. Okay. Thank you, sir. So one more question can I ask?
Of course, yep.
Sir, what's your experience with patients with a Currarino syndrome having a split cord malformation or tethered cord syndrome?
I'm sorry, what was the syndrome?
Currarino. Yes, sir.
So Currarino's triad is the triad. We wrote a paper, probably not very well known, where I proposed the embryology of Currarino's triad because I had a case. Of course, Currarino's triad is a anorectal malformation, a caudal sacral bony mass, and a spinal cord tethering. And I'm sorry, the classic, the third part of the triad is an anterior sacral mass, which is either a sacral meningocele or a sacrococcygeal teratoma lying anterior to the sacrum and coccyx. Right? So that triad is Currarino's triad, and a number of those are genetic, And people are getting to the genetic disorder, which is going to be interesting when we try to figure out the embryology of this. I had a case that was associated with a split cord malformation. One of the hemichords went down through a hole in the bottom of the sacrum and ended up in the attached to the teratoma. The other hemichord stayed within the canal. And so I proposed that this was a problem with what I called dorsoventral separation in the tail bed, or the Henson's node, the remainder of Henson's node, the cells of which are multipotent and give rise to the urogenital and gastrointestinal systems in their ventral aspect, and the dorsal aspect to give rise to the caudal notochord and the caudal spinal cord. That's that secondary neurallation part. And so I proposed that maybe it was a failure of dorsoventral separation during gastrulation, because this one was associated with a split cord malformation embryologically. So with respect to what to do with them, I think you need to close off their connection to the ventral meningocele. Usually it's a small stalk, hole in the dura that goes to the meningocele, and it's usually pretty straightforward to close that off, and or resect the teratoma. And then, of course, look for an underlying tethering lesion. Does that answer your question?
Yes, sir. Yes, sir. Yesterday in my outpatient department, I met with my operated kid. That kid was 2 years old, the Curano syndrome. The kid is having hypertelorism and low-lying tethered cord, which we have operated, and she is fine. And there was a coccygeal skin dimple, which we have discussed. That dimple, that we have left it undisturbed. The mother was very curious why you have not managed this dimple. Then I somehow convinced her that the main problem was the one which we have operated already. This need not to be bothered. So
yeah. So you already explored the dural sac and eliminated any tethering lesions.
Yes, sir. Yes, sir. That part I have done. That dimple I left untouched. I thought I should not disturb that because that was not having any discharge or nothing. So as you told that is okay, sir. That I can.
Yeah, I think so. Go back and look at your MRI scan and see whether the tract goes down to the tip of the coccyx, which I suspect it will.
Okay.
Of course, with a dysplastic sacrum, it might be difficult to really see on the MRI, but it would be interesting to look at that.
Okay, sir. Okay. Thank you very much, sir. Thank you.
But I would agree. I think that I would not be quick to, if it's truly a coccygeal dimple and it's within a few millimeters and you can put your finger on it and roll it around the tip of the coccyx, I wouldn't touch it.
Okay, sir. It was definitely 2 to 3 centimeters away from the anal verge, as it should be, as you told. So
centimeters or millimeters?
No, sir. It's almost 2 centimeters proximal to the anal verge.
Okay.
1 inch, 1 inch, less than 1 inch.
Yeah, so most of the literature suggests that true innocent coccygeal dimples will be within 1 centimeter of the tip of the coccyx.
Okay.
So if it's 2 centimeters, I'd be a little bit more. I don't know that I would explore it, but I would be a little bit more concerned about whether or not it's a problem. But I think if the child didn't develop some sort of infection, and you've already explored the dura, so if you section the phylum, I assume when you did your intraoral exploration, yeah, and you didn't see any other tract, so I kind of would make the assumption that that doesn't certainly doesn't travel up in the dural sac. So could it enter the dura and just stop there and serve as a portal of entry? Possibly. I think extremely unlikely. But if the child developed a meningitis, I'd probably look at that a little bit more carefully.
Okay, sir.
Thank you. Thank you, Dr. Maria. Dr. Das, do you have another 10 minutes to field questions? Are you happy?
I have as long a time as anybody wants to stay on.
Excellent, excellent. Thank you very much. 2 small questions. And once again, if anyone from the audience wants to ask questions, please just put your name on the chat box and I will invite you. Dr. Das, I come across these terms atretic meningocele or myelomeningocele. I try to look it up to see what people mean by that. does that, what does that word mean to you? Is it, that's a problem with the dysraphism, so many nomenclature
Yes.
in the system.
I'm not, I don't know that I've ever come across atretic myelomeningocele. I've come across atretic encephaloceles, which are, of course, almost all of them are parietal or occipital. And sometimes they look, and I didn't include that in here, but the skin lesions can look suspiciously like, and do have some overlap, at least when you look at them morphologically, with cutis aplasia congenita. It's typically said that the atretic parietal encephaloceles have a horse collar around them, that they have a whorl of hair with dysplastic skin around them, and they have a tract that typically goes down and bisects the superior sagittal sinus and travels variably within the falx. They also have abnormalities of the deep venous drainage system. They have what's called a primitive prosencephalic vein or an interfalx vein. And they typically lack or have a very dysplastic looking straight sinus. So straight sinus often is missing, and in its place is this primitive prosencephalic vein that goes from behind the splenium of the corpus callosum, from the galenic system, upward and inserts on the dura, typically underneath the atretic encephalocele. You don't have to chase, by the way, the tract. I typically have just cut the tract off flush with the dura and not tried to chase it down between the two edges of the superior sagittal sinus, fearing that would be a complete disaster. And I've not yet encountered anybody who's had any long-term consequences of that. The atretic myelomeningocele, I mean, there are, as you can see from this picture, that myelomeningocele, and I'm talking to people who probably have a lot more experience closing myelomeningocele than I do, quite honestly. But they come in a whole variety of sizes, and some of them, you swear, are closed. But if you look, they're almost, I say almost always, there's a little tiny area at a minimum of placode on the there, or you'll see the spinal cord will come up underneath and will attach to the dome. And it may be that some of these myelomeningoceles and the myelomeningocele and the meningocele may merge one with another. In other words, a true myelomeningocele is a failure of neurallation, right? So it's the neural tube stays open. I think the meningocele is a disorder of disjunction, where there's a tract of peripheral nerve cells and dorsal root ganglia that attaches to the inside of the dome of the meningocele. But you can imagine a sort of somewhere between that, where there's a tract of tissue that comes up from that spinal cord and attaches to the undersurface, but the skin's managed to fully form over the top of it. Be the one exception that I would say maybe what you're hearing or being referred to as atretic myelomeningocele.
Thanks. Thank you very much. I had two patients with at the level of the trocula, a small skin bleb that was rather red, not infectious, but rather red and painful, and one actually bisected the inferior sagittal sinus, and I think I discussed with my colleagues, and they said, Naren, just leave it alone, if you want to have a life, peaceful life. And is that a reasonable thing with the trocula not far away, trying to if there was any infection or anything like that, then I will try to sort it out. But otherwise, just conservative management doesn't seem. What's your thoughts on? I know you haven't seen that, but I was just wondering.
Right. I've had, I think, 3 now occipital ones that went, and they all are right at the occipital protuberance. They all go toward the inferior part of the torcular, right? and project downward. And you get, there's a bony opening, so you make a couple burr holes, you take off your piece of bone, you follow this track, and it's sort of stuck to the inferior edge of the torcular. And what I've done was to take that very gently and sort of put it on some tension, and with sharp scissors and a sharp microdissector start sort of peeling. And in all three cases, I was able to gently peel it off the out. I found that there was, at least in these three cases, there's a dural layer at the bottom of the tract, or deep to the tract, that separates the tract from the inside of the sinus. So a little bit of gel foam, a little bit of sharp dissection, and a little bit of sharp blunt dissection, and get it down below into the dura. And then it kind of just channels into the post-fossa dura, but is separate from it. In the one case that I showed here, it actually pierced the dura below the torcular, and I was able to open the dura below it, follow it in, and that's where it ended in this big dermoid cyst, dermoid mass. But yeah, it's scary. And the thing I worry about, and I certainly, if you don't follow it all the way and take all of it out, I worry obviously about a dermoid or epidermoid. So I would probably image those patients every couple of years just to make sure there's not something developing.
Okay, great, thanks. Thank you very much. That's very.
I did see a question about limited dorsal myelin. Yes. Peng, and I was a resident at the time, so I really didn't have much of a say in what we called it. But he referred to it as limited dorsal myeloschisis. He liked that term, where the last little bits of neural tube closure didn't happen. And so limited dorsal myeloschisis was just this failure of the last bit of neural fold closure. And as you probably know, Doug Cochran and Paul Kessel, or John Kessel, talked about it being a myelocystocele. I talked about cervical myelocystocele, where the central canal kind of comes up and balloons out into this dome. So you have, and if you followed it down, they thought that it would go into the central canal, the spinal cord. And for those that are not associated with split cord malformations, that's probably true. Whether that's a limited dorsal myelocystis or limited dorsal myeloschisis, whether you call it a myelocystocele, whether you call it a cervical myelomeningocele, I think all three of those are technically probably correct.
Thank you. On that question, where obviously embryology or dysembryology doesn't work in quantums, it will probably stop wherever it wants to, and then kind of confuses, doesn't come in nice neat packages. How do you manage to rationalize when things don't come up in nice neat packages of what we classically know? Because probably the common ones are not so classical.
Yeah, I mean, I have to tell you that I have, made a little bit of a career out of looking at these and looking at the variations and really pondering how does that fit with, and that's what excites me. How does that fit with what we currently know about these things? And so you get these one-offs, like the Currarino's triad that I saw that had one hemichord going down and ending in the teratoma. That really sort of started to advance my understanding of Currarino's triad. Another embryologic entity called, I'm blocking on the name now, but it's a spondyloptosis essentially of vertebrae. It's a congenital lesion where the spinal column comes down and literally there's a break in it, and it's often associated with a tethered cord lesion. A congenital vertebral dislocation is what it's called. Different from segmental spinal dysgenesis, which is another disorder. But I had a couple of patients with congenital vertebral dislocation, and I started thinking about it, and I thought, well, maybe this is because of embryonic buckling. So we have this flat embryo that's developing, and all of a sudden there's a mechanical force that actually literally buckles the primitive streak and perhaps the neural tube very early on. And so and for a variety of reasons that I talk about in the paper, I think this is a very early phenomenon. And these children generally are not paraplegic. And so you think, well, if it happened later in embryogenesis, it would crush the spinal cord, but it doesn't. And the pedicles are very long. So it has to have occurred before we set up the bony vertebrae. And so I came up with this congenital vertebral buckling hypothesis. So that's this kind of stuff that really fascinates me.
That's great, thanks. There are two questions, two general questions, then I will come to more controversial questions to you, Dr. Das. I think you can read Dr. Maurya's question. I think it's a very broad question. What's your observation about the most common causative factor for spinal dysraphism? Certainly in US, what would you think the cause of it? I'm sure that in developing countries, it might be different.
Hello, sir. Sir, Ved Prakash Maurya, sir.
The question Dr. Maurya is asking is, what's your observation about the most common causative factor for spinal dysraphism?
Yes,
about
sir.
the most common of occult spinal dysraphism?
This entire spectrum, sir, like meningomyelocele, tethered cord.
Which is most common, you said?
What is the most common causative factor? Etiology, most common etiology of these spinal dysraphism in your part of the world? Because I belong to India, in the northern part of the country, Indian subcontinent. Here, we most commonly encountered that lack of folic acid supplementation during gestation.
Yeah, I think we don't. I think that, well, myelomeningoceles, of course, have a multifactorial causation, and folate is involved in some manner, probably related to methionine synthesis and the methionine cycle. The folates, and it's one of those where probably there are a variety of genetic abnormality mutations, and none of them have been identified in the system. Of methionine synthesis that involve folate. And so what almost certainly happens is that some patients have mutations that require, or that in which folate, the enzymes that require folate, and I think it's tetrahydromethyl folate reductase, I think, or I forget what it is now, don't work very well. And you can it seems that you can overcome that by adding more folate and driving the system. And so it's not a folate. I mean, obviously, if you have an absolute folate deficiency, even with a normal system, you get a failure. But for those who have mutations that make them more susceptible to neural tube defects or failure of neurallation, you can overcome that with folate supplementation. The rate or the incidence of neural tube defects, of myelomeningoceles in particular, worldwide is going down. And some of that is folate supplementation. Some of it is early termination of pregnancy. And there is a component that we don't understand at all why that's going down. So part of it, we don't have a clue, as far as I know, why it's gone down like that.
Thank you, Dr. Das. That's a question from Dr. Bassam Adas. Do you see babies with myelomeningoceles and areflexic bladder develop detrusor hyperactivity or detrusor sphincter dyssynergia later in childhood?
Yeah, I'm not a urologist, so my answer is perhaps not that of an expert opinion, but yes, we do see that, and some of them are due to spinal cord tethering, and I think some of them are just. I think they probably are a level of, for lack of a better term, maturation or change in the system. And so it's kind of interesting because way back quite a while ago, there were a number of experiments on children with myelomeningoceles in which people did recordings and stimulations of them during surgery. And what they found was that, for example, if you stimulate the plateau, you can generate you can generate EMG and nerve conduction. And of course, we all have that experience where you mess with the placoid or you cut a nerve and the leg jumps. And so that limb is intact. You can do somatosensory evoked potentials from the lower extremity, and you can record from the placoid. But you can't stimulate the placoid and get a sensory motor response farther cranial. And if you do transcortical motor stimulation, you can pick up recordings from the placoid, but you can't get any further response, and so or farther down. So there's all of those put together suggest that there is a disconnect between the upper motor neuron and this placoid that has the circuitry within it, and very often has sensory input and motor output, and you have reflexes. Interestingly, you don't have hyperreflexia, which has always puzzled me in that case. So you can have detrusor sphincter dyssynergia and a hyperactive bladder, which we consider to be an upper motor neuron thing, but you've got somebody who's areflexic in their leg. So it's not just that, but it's thought to be the intrinsic circuitry of the cord and the connections from more cranial to the placoid that are at fault. And it may be that as the baby grows, those connections, the lower motor neuron reflex connections, become more robust, and of course are disinhibited by not having the inhibition from above. And so some of it could be a change in the intrinsic circuitry of the cord as the child ages. I don't know. That's pure speculation on my part.
Thank you very much. We are hoping to have a lecture on urology in the subsequent months, because that's one area that's even many urologists I have asked are shying away from giving a lecture, and even they don't I think feel so confident about it. Dr. Daz, I'm just slightly going to go slightly from the talk and ask you two controversial areas, because just to know your practice. In terms of the radical resection of lipoma that Dr. Pang has beautifully shown very good outcomes in his series. And how is the take-up of that in states? That's number one. The number two is that, I'm not Dr. Pang. I'm hoping one day maybe Dr. Dias or Dr. Pang, but trying to take a child who's neurologically intact and prophylactically do operation, and with a risk of not making the child better, but certainly there's a risk of getting the child worse. You have to come to Southwest England if you want to really have the parents being hyper anxious. What are your views on those two things, Dr. Dias?
I'll take a little bit of a long and somewhat circuitous answer. Let me start out by saying that I no longer do surgery. I'm 64, and I've given up most of my clinical practice now. I do mostly education of medical students, some administration, and the research in the National Spina Bifida Patient Registry, and my other love of abusive head trauma in children. Not love of abusive head trauma, but research on abusive head trauma. And the reason I bring that up is because the reason that I'm retired from clinical practice largely dates back to 2019, when I had a newborn infant on whom I operated within the first month or so of life with a spinal lipoma. And Dr. Pang trained me, and I learned that technique as a resident. There are other people who violently disagree. Paul Kanev, for example, is of the opinion that you cannot do that because the spinal lipoma histologically has fingers of fat that infiltrate into the spinal cord substance. And so any attempt to try and find a plane is going to be fraught with disaster. I know Dr. Pang. He is an honest individual. He is also a phenomenal surgeon. So when he published his paper, I was not surprised at the result. But I have, to varying degrees, tried to be as aggressive as I could with taking lipomas out. Often I'd chicken out, and I would, and when in the early parts of my career, actually I did, when I was with Dave McClone, I adopted the laser technique, and then I went back later in my career to the Pang method. Anyway, this infant that I operated on, everything went perfectly with the operation. I found a nice plane between the fat, and there was this gristle, and I couldn't debulk the cord. And Pang has talked about this. I forget what he calls it, but it's a kind of a firm. It's not fat. It's a firm section between the fat and the cord. And I couldn't neurulate the cord without taking that out. And Pang takes that out as well. And so I, in bits and pieces with the microscope, took out little pieces of it and kept shaving it down, almost like a falafel, taking little pieces until I got really quite down close to the cord. In fact, there was one little tiny area where I was pretty sure I got through it and just started to see cord substance. And I stopped. We had monitoring. It went great. There were absolutely no changes in anything, not even a burst of activity. And the post-op MRI scan the next morning looked great. The child woke up and was completely unable to void. And as far as I know, remains unable to void and is on a straight cath regimen. I bring this up because it's totally unrelated to the embryology talk, but in the interest of full disclosure, I'm very interested in this whole process of psychological and emotional trauma to physicians, and particularly surgeons, when we have bad outcomes. I, in the aftermath of that operation, I was so upset that I eventually quit neurosurgery. I quit my neurosurgical practice because I turned to my wife in the car on our way back from the beach, where I should have been having a great time 3 days after this operation, and instead I was a million miles away, as I'm sure many people on this listserv can attest. And I turned to my wife in the car and I said, I don't want to hurt anybody anymore. I mean, I literally remember saying that to her. So in a long-winded answer to your question, I think that trying to do that, and I talked to Dr. Pang about that case, and he didn't have really a good answer for me as to why that child had it. And like you, Naren, I've always looked up to him as being sort of the quintessential, wonderful, technical whiz that he is. And I think of myself as being sort of mere mortal. And I think that goes to a lot of different things, right? Craniopharyngiomas come to mind, that people say that they have great results. And now we know that, in fact, subtotal resection and radiation, I think there's very good evidence that it works quite well, equally effectively and with less morbidity than trying to get every last little bit of the craniopharyngioma out. There's a lot of chest thumping that goes on in our profession, and I think that we need to try and balance that and the results that people get or seem to get. And I will freely admit that there are papers that I've read and people that I've known in the literature that I'm convinced that their results are not true, that they're exaggerating their results. And I think Dr. Pang is not one of them. But it really bothers me. This is obviously going way off target here, but I think there is a lot of frankly, exaggeration and perhaps even out and out lying about results. And then the rest of us try and emulate that and don't get the same results. And we beat ourselves up because we can't. And maybe in some cases it's because the results that are recorded in the literature are not correct. They're not the real results. So
I think
back to your question about lipomas, what would I do now? Trying to remove as much as I could, but I like craniopharyngiomas. You go at it with the thought, well, I'm going to try and get as much of it out as I can without hurting the child, and try and stop just before I injure the child, which of course is impossible. You can't stop doing something just before something bad happens, right? You never know when something bad is going to occur.
I think if I obviously if you are mortal, I'm just a baby, but I have I have to agree with you on that, on the point that, I think it all from, I have observed many practices. I have, been around, and my feeling sometimes is that, sometimes you might, someone can be exceptionally good after going through the learning curve, and in a particular institution where they can operate as long as they want without any problems and 24 hours. In many institutions in UK, if you go after 5 o'clock, you are in trouble. And so you are trying to get through quickly, or so you don't have that that kind of setup that you have to do, and the publications might be after the learning curve, which don't show what was the part of the learning curve. I'm just speculating. And the other thing is, I think the other thing is that I do agree with you that I have asked so many people to give me videos of the radical resection of lipomas, and no one has ever given me yet, or really even replied back to me. And so, and the other thing is that I've seen some fantastically good vascular neurosurgeons who do operations very fast, etc. And I nowadays don't believe unless I see the outcomes myself. And not, it's you can do a beautiful operation and show a nice scan, but the question is how the kid at the end of it. But that's one. The other controversial question, Dr. Dias, is about intrauterine repair of myelomeningocele. I just, I might be just biased. I might be slightly someone who questions before jumping, because I think historically we have had so many operations where was supposed to be the panacea, and then we, sooner or later, very long later, we come to know that this wasn't. Are we going just based on one randomized controlled trial, this intrauterine, and is it are we actually questioning into, or is this a gravy train that's going? What's your thoughts on that, and particularly the maternal mortality? And I have, there has been reports of endoscopic repair with mortality, certainly in UK as well. And once again, there's a lot of chest thumping, etc., etc. And I just, from your thoughts, so that I might be biased, but I just wanted your thoughts from a long experience.
Yeah, I wrote an editorial once for Pediatric Neurosurgery after one of the early reports before the MOMS trial, in which the authors said that they concluded, and there was one where this is one where there was at least one patient who mom had to be taken and the baby delivered emergently because she had a uterine rupture. And so their conclusion with this series, and speaking of sort of inflating your results, this was talking about the open technique, but it included some patients that they had previously reported that, interestingly, when you counted up the numbers, I can't remember, my editorial was such a long time ago, but when you counted up the numbers, it was clear that they had neglected to include fetal death that had happened if you looked at it from other sources. But their conclusion was that this was a safe and effective treatment for, it could be done safely. I think they didn't talk about effectiveness at that time. But my comment was, if you had a uterine rupture, that, to me, it means that you can't say that it's safe. There's some risk both to the mother and the fetus. That could have ended up very differently. I do think that the MOMS trial was well done. It was well reviewed, and it was well coordinated by the people at, I think it was Washington University, as I remember, George Washington University, which was separate from the trial sites. I think it was done well, and I think some of the results, clearly that some of the results have been good. There's not been another MOMS trial, but I think they're continuing on. And I sort of lost track of their more recent stuff, but the main concern I have is the people who were doing this, as you said, were, as we talked about in our previous discussion, were the experienced ones, and they went through their learning curve. And now we're opening it up to other places. And I think there is an element of gravy trainism where everybody needs to have a prenatal program in order to, attract referrals to them and away from surrounding sites. And I'm speaking from a place that doesn't have a fetal surgery program and is an hour and 15 minutes away from a place that does have a fetal surgery program in Philadelphia. But I think that as we open this up to other areas that unlike Vanderbilt and Philadelphia and UCSF that are very experienced and do things well, that the complication rates, both for the fetus and for the mother, are going, of necessity, are going to be higher as people learn how to do this. That doesn't mean that the technique won't be ultimately deemed to be appropriate, and there are certainly some benefits to it, particularly with the reduction in hydrocephalus, the both anatomical and now demonstrated functional outcomes from the Chiari malformation being improved, and a small effect on sensory motor level. I would think a small effect. I'm not sure that it justifies doing it for that reason. But yeah, I think that we need to be very cautious as we move forward with this.
Thanks. Thank you very much. Last two questions, Dr. Dias, is from Dr. Maurya again. I think it's very useful question. He's saying, do you detether mandatorily as routine in all cases of MMC, Meningocele, and SCM, spinal cord lipoma cases? Do you always untether with all these Dysraphisms? Because sometimes you have done the operation enough, you just want to close and get out. And
so for myelomeningoceles, I do the initial closure as I was trained. I completely, it involves an untethering, right? You're releasing the spinal cord from the surrounding tissues. And so the initial closure is an untethering. And so once that's done, I don't untether a second time unless there are symptoms that I think are due to tether, right? And of course, I always, as Dave McClone taught me, and which I've trumpeted on since then, it's always the shunt until proven otherwise. But for myelomeningoceles, I can sort of consider that you've done your primary untethering at the time of birth. For all other occult dysraphic malformations, of course, again, I think we need to do an initial untethering, prophylactic, and so I'm in favor of doing prophylactic untethering. And I think people in this country almost universally are of that opinion. And then once that first untethering is done, that primary untethering, any subsequent tethered cord release is reserved for recurrent symptoms that you think are due to tether.
I have seen cases, Dr. Dias, where myelomeningocele has been repaired and then there's a tether with what appears to be like a phylum terminal. Do you always divide the phylum terminal when you do the myelomeningocele repairs?
Yeah, and I took that slide out of this talk in the interest of time, but there are a minority of cases where the phylum is still present. In a lot of the cases, you can't find a phylum, or at least I can't find a phylum. But there are cases, rare, probably 5 or 10%, where the phylum is present. If you see a phylum, yes, I believe you should cut it. And that was Dave McClone's view as well.
Great, thanks. There's a question from Dr. Gopalakrishnan Chittur. How early do you operate on dermal sinus tracts? Would you do it as soon as possible, as soon as it's diagnosed?
Within reason. I personally don't think there's any reason to wait in an infant for them to attain a certain age. I wouldn't do it right at their time of when they're newborns. I'd let them go home, let the parents bond, see them as outpatients, schedule the surgery. But I would do them. I usually do them within the first 6-8 weeks postnatal. I don't see a reason to really wait longer than that.
Great, thanks. This is the last final question, and if I may ask that one, please. In terms of the occult tethering, where the spinal, the conus is at the normal level, but the patient has bladder problems, and in those patients, have you come across occult tethering, and do you believe in untethering in these occult tethered patients, and have they got better after you untethered? If you have, thanks.
Another great and controversial question. So there are two scenarios. One is the spinal cord that ends at a normal level but has an identifiable tethering lesion, right? So you have a spinal cord that ends at or above the mid body of L2, but has a fatty phylum, and we know that fatty phyla there can normally be some fat in the phylum, and that doesn't necessarily mean that that's pathological. But I've encountered patients with normally positioned conus with an abnormally large and or fatty infiltrated phylum, and in those patients I don't have any problem with untethering them. And in general, when it comes to abnormalities of the phylum terminale, I have a pretty low threshold for that one operation cutting the phylum, because it, at least in my hands, and I think in everybody's hands, it's such a simple, straightforward operation to do. It takes 45 minutes. You know, you can almost do it interlaminar between L5 and S1. And so I've had a fairly low threshold for doing that. I have had a small number of patients of the second type, which is what Monica Waby, I think, has advocated, totally normal, right? So a normally positioned phylum, normally positioned conus, normal phylum, no tethering lesions, but who have, bladder spasticity issues. Some of them have pain and so on. My experience with those has been very disappointing. I've not done a large number of them. The ones that have improved seem to me have improved for a period of a few months. And then they come in, and their first post-op visit, they'll come in 3 or 4 weeks later, and the parents are like, this is great. They've stopped, doing all the things that they did before. They seem to be much better. And then they come back, like, okay, come back in, another 6 months. And they come back and they go, yeah, about a month or two after I saw you, they went back to where they were before. By the way, I always get preoperative urodynamic studies in those patients, and have never operated on one without getting some formal urodynamic objective measures. And I've gotten them post-operatively, probably all of them. I don't know that I have an exception, have really returned to what by the time they got their post-op urodynamic studies, they were back to where they were before. So I personally have been disappointed.
That's brilliant. Thank you very much, Dr. Dys. I'm sure that all the other participants here also are, very grateful for this absolutely fantastic lecture. You took us through all the dysraphisms, the embryology, and as I said, it's always nice to see them and hear from someone who has gone before it comes and hits you, and then you are scratching my head. And thank you, sir, and thank you also for taking the controversial questions. And I hope you will please join us in the future grand round. Certainly, we will have to have one on NAI. I'll talk with you, because I know that's another passion, and you are a leader in that. Thank you very much, and thanks to all the participants. And I will put the recording on the YouTube, hopefully within the next 24 hours, and so you can all review it again. Thank you very much, and please give my regards to everyone in Hershey, Dr. Harbour, Dr. Cockcroft, and Nancy as well. Thank you, sir. Much obliged.
I will. And thank you, Naren. That was what you're doing here is a phenomenal thing for education for all of us worldwide.
Thank you, sir. Thank you very much. Thank you very much. Bye for now. I'll leave the chat box and the system. So if anyone wants to talk to Dr. Dys, if he has time, or among yourself, you are welcome to chat for the next half an hour. Thank you.